Somatostatin analogues Octreotide and Lanretotide. Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon, and if you or someone you care about has been diagnosed with neuroendocrine tumors and you're wondering about somatostatin analogues, you're in the right place. I know terms like Octreotide and Lanretotide sound overwhelming, but today we're going to break down exactly how these medications work for both symptom control and tumor growth. Before we dive deeper, let's establish what we're dealing with. Somatostatin is a naturally occurring hormone in your body that acts like a biological off switch. Octreotide and Lanretotide are synthetic versions that treat neuroendocrine tumors through two mechanisms. They control hormonal symptoms that affect daily life, and they slow tumor growth. That dual action makes them uniquely valuable. Somatostatin analogues, or SSAs, bind to receptors on tumor cells, particularly subtypes 2 and 5. Now, what does this look like in real terms? First, they block hormone secretion, like serotonin, which causes flushing and diarrhea. Think about having 10 to 20 bowel movements daily. That's life-limiting. SSAs can bring this under control within days to weeks. But here's where it gets interesting. These same receptors slow tumor growth through multiple pathways: direct effects on tumor cells, reduced blood vessel formation, and immune system effects. You're putting brakes on the tumor while feeling better symptomatically. If you're supporting someone through this, understanding this dual benefit helps explain why they might feel better, while also benefiting from tumor control they can't directly see or feel. Two landmark trials demonstrated SSAs aren't just symptom controllers, they modify disease. The PROMID trial studied Octreotide LAR 30 mg monthly in mid-gut nets. Patients on Octreotide had stable disease for a median of 14.3 months before progression versus 6 months on placebo. That's more than double the time without worsening. CLARINET studied Lanretotide autogel 120 mg monthly in gastroenteropancreatic nets. Progression-free survival wasn't reached in the treatment arm during the study versus 18 months on placebo. Quality of life was maintained or improved. If you already have nets, these trials show earlier treatment provides better control. The CLARINET extension study showed continued benefit over longer periods. These aren't small improvements. We're talking meaningful extensions in disease control, translating to more time living well. Octreotide LAR is given intramuscularly at 30 mg every 4 weeks for anti-proliferative effect, the trial-proven dose. Lanretotide is 120 mg subcutaneously every 4 weeks. Now here's an important practical point. Octreotide LAR takes 14 days to reach steady blood levels, so patients with moderate to severe symptoms may need short-acting Octreotide 100 to 500 micrograms every 6 to 8 hours during the first 2 weeks. Lanretotide reaches steady state on day 1, potentially avoiding this bridging therapy. If you're worried about someone starting treatment, knowing short-acting medication provides rapid symptom relief while waiting for long-acting buildup can ease initial concerns. SSAs are generally well tolerated. Only 1% stopped Lanretotide, and 12% stopped Octreotide due to side effects in trials. Most frequent are gastrointestinal abdominal discomfort, nausea, and flatulence, typically resolving within 2 to 3 weeks. Gallstones developed in 10 to 14% of patients. If you develop right upper abdominal pain, especially after eating, the gallbladder may need removal. Some surgeons remove it preventatively during other abdominal surgery. Pancreatic insufficiency develops in almost 1/4 of patients, usually 6 to 24 months into treatment, causing fatty, foul-smelling stools. This responds well to oral pancreatic enzyme supplements with meals. Hyperglycemia occurred in 5%. If you have diabetes, expect closer monitoring and possible medication adjustment. Vitamin B12 deficiency should be monitored and supplemented. Fat-soluble vitamin deficiencies, particularly vitamin D in 28% of long-term users, require supplementation. If you're supporting someone, understanding these effects are manageable, not inevitable, helps maintain perspective. Before starting, you need baseline CT or MRI and somatostatin receptor imaging confirming your tumor has the right receptors. During treatment, imaging every 3 to 6 months is recommended, depending on tumor grade. For grade 1 small intestinal nets, 6 monthly imaging is typical. For grade 2 pancreatic nets, every 3 months initially, extending to yearly once stable for 3 to 5 years. Measure biomarkers like chromogranin A at 3 months, then, with imaging. If you have carcinoid syndrome, NT-proBNP measurement yearly or every 2 years detects carcinoid heart disease, which develops in up to 20% of patients, decreased from historical 50% rates, likely due to SSA use itself. Start a detailed symptom diary noting frequency, severity, and triggers of flushing, diarrhea, or low blood sugar. Stock up on easily digestible, low-fat foods for initial treatment weeks. Compile all current medications and supplements your team needs to complete this list. Arrange for someone to accompany you to first injections for support during adjustment. Has my tumor been confirmed to have somatostatin receptors? What's my receptor expression grade? This determines if SSAs will work. Are we starting at 20 or 30 milligrams Octreotide, and why? Understanding anti-proliferative benefits of higher doses matters. Do I need short-acting Octreotide initially? The answer depends on symptom severity. Should we do a baseline gallbladder ultrasound? What gallstone symptoms warrant a call? Establishing a baseline helps detect problems. How will we monitor for pancreatic insufficiency, and when would we start enzymes? Knowing timelines helps recognize issues early. Should I start vitamin D and B12 now, or wait until levels drop? Some centers prefer proactive supplementation. Same-day evaluation needed for right upper abdominal pain with fever suggesting infected gallbladder, severe persistent diarrhea with dehydration despite treatment, or carcinoid crisis symptoms. Schedule within a week for new or worsening steatorrhea suggesting pancreatic insufficiency, new onset or worsening diabetes symptoms, or unexpectedly rapid weight loss. Routine scheduled monitoring, annual or biannual cardiac imaging if you have carcinoid syndrome even without symptoms, regular tumor markers per schedule, and vitamin levels after 6 to 12 months, then yearly. Let me quickly recap. Somatostatin analogues offer dual benefits, controlling hormonal symptoms while slowing tumor growth based on strong trial evidence. Your next step: schedule a consultation with your NET specialist to discuss appropriateness for your situation, ensuring receptor-positive disease is confirmed. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.